Hello, thank you for attending the third panel as part of our Dissemination and Implementation Science Speaker Series. Because we have only an hour, I'm just going to briefly introduce myself and the speakers, and then hopefully they can just jump right in to the talk. So first introductions, my name is Brianna Last. I'm an assistant professor in the clinical area of the Department of Psychology at Stony Brook University. And as many of you know, the Dissemination and Implementation Science Speaker Series is part of a project funded and supported by the Academy of Psychological Clinical Science. The overall goal of the project is to strengthen dissemination and implementation science training across clinical science training programs. And throughout the series, we've invited leaders in dissemination and implementation research and practice to share their insights from research and practice with the broader clinical science community. So today's panel, Supporting Clinicians in Implementing Evidence-Based Practices, features esteemed panelists, Doctors Rinad Beidas and Shannon Dorsey. Both Rinad and Shannon have been leaders in the field of dissemination and implementation and have thought about how we can make implementing EBPs easier, more appealing, and more routine for clinicians. And we're so lucky to have them. So let me briefly introduce them. So I can't do justice to their immense scholarly accomplishments. So I'll just kind of let their presentations reveal their brilliance and just kind of share their affiliation so you know where they are. So Dr. Rinad Beidas is chair and Ralph Seal Paffenberger, I hope I said that right, professor of medical social sciences at the Feinberg School of Medicine at Northwestern University. In addition to being an outstanding researcher, she was also my PhD advisor. And she is not only one of the best mentors a person could ask for, but she's also a wonderful and caring human. So very excited to have Rinad here. Dr. Shannon Dorsey is professor and associate chair for graduate studies in the psychology department at the University of Washington. Shannon is an internationally renowned scholar in the field and is also one of the kindest people I've met. So super excited to have Shannon here. So for those who are new to the series, each panelist is going to speak for about 15 to 20 minutes, and then we'll have a question and answer period. I'll begin the question and answer period with just maybe one or two questions just to start us off before opening it up to the audience. So please hold your questions until the end so we can have a robust discussion. Should you experience any technical difficulties or have any questions during the panel, you can write to Laura Jans and Madeline Papard. Laura and Madeline, do you want to just like raise your hands? They're there. And if you'd like to view the presentation with closed captions, you can click Show Captions on the bottom bar of your Zoom screen if that would make the presentations more accessible to you. And we'll also be monitoring the dissemination.implementation Gmail address if you get logged out of the Zoom call for any reason. Okay, without further ado, I will let our first panelist, Rinad, speak. So Rinad, do you want to take it away?
I can take it away. And I just want to start by thanking Brianna for their leadership in organizing this panel, and Madeline and Laura for all the helpful support that you've offered. I'm really excited to be here for a lot of reasons. It's also good to see some familiar faces and meet some new folks. And I haven't seen Shannon in forever. And Shannon, I miss you. I'm saying it publicly. So looking forward to hearing what you have to share and being in the same virtual space. So I'm going to go ahead and share my screen. And if somebody can give me a visual confirmation that you can see my deck, that would be fantastic. Okay, thank you so much. All right, I'm going to try to keep it at 15 to 20 minutes. So hold me to it. So I just want to start by acknowledging that a lot of what I'll be sharing with you today builds from experiences that I had working in a close partnership in the city of Philadelphia with colleagues for about a decade, focused on supporting clinicians in the public behavioral health system. And so much of what I will share comes from those observations and experiences and from what my colleagues and partners taught me. And this is a non-exhaustive list of everyone who is involved in that work, but that's really what I'll be drawing upon. And I have kind of three main points. I know it's lunchtime. Well, it's lunchtime in Chicago, so people might be post-lunch on the East Coast, and I want to make this simple. the first main point that I hope you take away from the presentation is that amplifying the voice of the clinician experience and delivering high quality care will allow us to better support clinicians. And so one of the greatest privileges of the work that I've been able to do in my career is actually shining a spotlight on the conditions that clinicians are experiencing and amplifying their voice, and they're the experts on what is helpful for them to implement evidence-based practice and deliver high quality care. Two, the second point is that training is not enough, and I'm sure we all already know that, but I think it's an important enough point to make it explicitly. And more recently, I've done some work applying principles of behavioral science with other colleagues to think about how to change the environment to support behavior change, knowing that training is not enough. And then finally, I'll talk a little bit about a trial that Shannon and I did, thinking about how to develop and deploy innovative approaches to better capture what happens between a therapist and their client in session that could be used in supervision, that could be helpful. So those are the three things that I hope you'll take away, and I'll go through each of them now. All right, so let's talk a little bit about amplifying the clinician voice. As I've already noted, I was very fortunate in that in my first faculty position at the University of Pennsylvania, I joined a center that had a very strong pre-existing relationship with the City of Philadelphia Department of Behavioral Health, which was how all care in the public behavioral health sector was delivered and supported. And my very first grant was a K-23 focused on understanding within a system that was committed to, that was supporting implementation of evidence-based practices, how that kind of happened. It was a naturalistic observational study. And, I went into that study really focused on my research question, as we often do as researchers. I was interested in kind of therapist factors and how they were related to implementation of evidence-based practice. So things like knowledge, attitude, self-efficacy, organizational factors and their relationship with delivery, like organizational culture, climate. But what ended up happening is, while that was still interesting over the course of the study, I came to learn so much from my colleagues in the community who helped us think about what meaningful questions we might pursue, which could amplify the voice of their experiences. And really, that allowed us to take a magnifying glass to the infrastructure of public behavioral health within that particular system. Some of you all may have seen me present on this before, but I think it's really profound in my thinking of how we do this work and how we support people and places do the thing, which is ultimately what implementation science is. Some of the work that we ended up doing, we didn't think we were going to do. We did it because we learned about it from our clinician colleagues, from the leaders of the organizations, some having to do with the incredible financial strain and stress and precarity that clinicians and organizations experience. And so this is work that Brianna and Danny and other colleagues are continuing on and producing much fresher, newer knowledge in. But this was kind of the original origin of starting to unpack the fact that when you talk to organizational leaders, they say things like, we're losing our shirt. We hold our breath and hope we're going to be able to pay everybody in the organization each month. And similarly, when we talked to clinicians, when we did surveys with them, they shared the immense debt that they carried and whether they could even get their own mental health care because of their financial situation. Really amplifying that was meaningful and really helped us understand kind of a broader issue around implementation of evidence-based practice. If the broader infrastructure and structure is not amenable and people are really having to focus on basic necessities, it makes it very difficult from like a Maslow's hierarchy perspective to do evidence-based practice. So takeaway there is we need more funding, we need more support for our organizations that are providing much needed mental health care to our communities. That line of work really led us away from being the experts coming in and doing the studying to really learning from our colleagues and wanting to ask them what they needed rather than, making assumptions or bringing our own kind of mental models in. What you see here is we did an innovation tournament, which was a kind of innovative participatory design approach. Think American Idol, but for ideas, with clinicians in our system and ask them, what do you need to be supported in doing implementation of evidence-based practices? And this event was a really meaningful one. Our former commissioner, David Jones, is pictured with the winning clinicians and our challenge committee. And it was a really special day. People brought their colleagues, they brought their partners, they brought their bosses. And I realized how powerful it is amplifying the voice of clinicians. And so one clinician raised how kind of chaotic and difficult the waiting room was, and how that made it hard for their patients to come into the session ready to do a trauma narrative, do difficult work. And so their idea was to make the waiting room a more conducive place to getting in the mindset one needs to do therapy. Whereas other clinicians who submitted winning ideas were focused on some of that financial strain that we described earlier, and incentives to do the extra work that's required to do evidence-based practice. And what's really cool is that the system that we were working with was able to kind of take ideas and deploy them within that system, which allowed us both amplify voice and make change, which is one of the coolest things about doing implementation science. So that's point number one. The next point is about training. And I actually think that Dr. Dorsey is the reason I have this comic strip here. I took it out of the vault. I haven't presented this in a long time. But actually, I've been thinking about training, turns out, for a really long time, almost 20 years. And so my early implementation work was all about training, because I came into this thinking there was a knowledge gap, and that was why people weren't doing evidence-based practices. And Dilbert obviously helps us understand that knowledge is important, but definitely not a major driver of why people do or don't do things. And I spent a lot of time deeply embedded within the community context that we worked within, and I saw our system, I saw people and places investing in a lot, really centering training approaches. And that's really important. Don't get me wrong. We do need excellent training and consultation and support to community clinics. But I also felt like, given the crumbling infrastructure that I described before, that sometimes I felt like we were maybe making things harder for them. And I became really interested in this idea of, is there a way to make implementation of evidence-based practice easy to do? Because it often felt like it wasn't easy to do. And I made my way through an existential crisis to behavioral science, or behavioral economics, which is a discipline that our team and others have been kind of trying to better integrate into this approach of implementation. I'm going to bring this to life a little bit, because when I say behavioral economics, people think I'm usually talking about financial incentives, and that's not what I'm talking about. So this is an example of behavioral economics in action. There's a subway, and Volkswagen painted these piano keys onto the stairs. And what do you know? People then choose to go up the stairs versus using the escalator, which is typically what people select for health promotion. Another example comes from an airport in Amsterdam. You probably can't see what's pictured there, but it's a fly. And so there was an issue in this airport bathroom, and maybe others, where there was a bit of a mess when people were using the bathroom. And so a fly was painted to help with some target, and that resulted in cleaner bathrooms. Another example, hopefully this is illustrating for you how changing the environment, the choice architecture, makes it easier to make particular choices. This is in London, and people, instead of throwing their cigarette butts on the ground, can vote for the best football player, Ronaldo or Messi. And so you can see that people are using that receptacle, and my son would say Ronaldo, no question. So finally, this is an example of these concepts at play in the digital world. So if we were in a room together, I'd ask you to raise your hand. How many times do you find yourself just watching Netflix for hours before you realize it's past? It's because the default is that the next episode just continues to play. That's a behavioral science, behavioral economics principle. And so a lot of the work that we've been doing over the past decade is thinking about how to redesign the environment to support behavior change. So moving beyond training, that's not enough by itself either. So we need organizational change, we need structural change, but it's this kind of suite of multi-level approaches. And I was really influenced in early days by this study led by Dr. Mitesh Patel, who was the first founding director of the Penn Medicine Nudge Unit. And what you see here is a graph. You see a lot of heterogeneity in the percentage of drugs ordered as generic. That's what you're seeing. And on the x-axis, you see dates. So on this date, November 15th in 2014, there was a change made to the electronic health record where the default became generic meds versus name brand meds. And you can see the power of that default where that heterogeneity really goes away, with the exception of a medication that prescribing clinicians prefer to prescribe name brand, which is Synthroid. And so this early study really influenced me, and I wanted to find this version for community mental health clinics. And I can't say that I have a picture that looks like this, but that was what really drove me. And this was work that I got to do with Brianna as well. They led a systematic review of studies in healthcare using behavioral economics and nudges, a lot of what I've been describing. You may also hear called a nudge in the popular press. And I'm just interested in how these additional strategies might be useful to us, but not as kind of a panacea. It's definitely part of the toolkit. I would argue not enough of a part of the toolkit for implementation science, but by itself also has its own potential for unintended consequences and shouldn't be the only kind of hammer that we use. And just to give a little flavor to this, Brianna led some work helping us kind of go into qualitative interviews with clinicians who are implementing trauma-focused CBT narratives in the city of Philadelphia, which was a group of clinicians that we worked with and supported, and to start to kind of apply some the themes that we heard to behavioral insights, which are these ideas like, what is your mental model of the delivery of care? What are the social norms? What default bias? And then come up with potential implementation strategies that could match those. And so because of my time, I'm not going to go too into depth on this slide, but it's a great paper. You should read it. And again, I'm all for incorporating this type of thinking, but I don't want people to think that I'm saying that it's the only way, and there's lots of limitations as well. But here are some ideas about how to incorporate more of this thinking, make it easy, attractive, social, and timely for clinicians to use evidence-based practice. Reduce sludge or friction. If you can take away sludge or friction for clinicians, they have more time and more goodwill towards wanting to implement evidence-based practice. Integrate within their workflow. And if you're going to be doing something really hard, make sure it's an organizational priority. And then the last thing I'll talk about before I hand it over to Shannon is to talk a little bit about our FACT study. And this study really came out of early work by Sonia Schoenwald, talking about the challenge and kind of capturing what clinicians do in session with clients in the real world. And as we all know, our typical approach for research settings, randomized controlled trials, are very difficult to do in kind of real world settings. And the reason it's important to know what happens in session is to help provide support to clinicians and to be able to provide more effective supervision. And so we did a randomized trial where we aimed to identify accurate and cost-effective ways to measure what clinicians did in session with their youth patients around CBT delivery. With the idea in mind from the beginning that these might be tools that we could use for research in the future and also for supervision. And so we had three kind of novel measures that we were comparing to the gold standard of direct observation and coding, which I know everybody on this call is well familiar with. And I'll tell you about each of these novel measures in a moment. And really, we were looking for concordance. So how much each of the novel measures looked like observation in terms of its ability to tell us what happened in session. And the way that we engaged in direct observation in this study, which was of like 300 plus sessions with about 100, and I think it was about 126 clinicians, is we audio recorded their sessions, and then we had research staff who were trained in Bryce McLeod's TPOXX RS code for 12 components of CBT. And of course, we know that it's likely the most accurate way to capture what happens in session, and we've used it in lots of familiar ways, but it's expensive and time consuming. And just for those of you all who may be less familiar with TPOCs, but given this audience, I'm guessing that's not the case. For each of the 12 components in the purple boxes, there's a score from 1 to 7 with regard to how extensively that particular component was used. And we compared that to self-report, and you were probably thinking, well, self-report's not that novel. It's been around for a long time. But we developed an enhanced self-report that was actually a measure that was co-created with community clinicians in Philadelphia, and mapped onto the TPOCs because there wasn't a self-report version of that. And of course, we know that self-report is cheap and probably easy to implement and commonly used, but there's a lot of downsides, including potentially lack of concordance with what occurs in session. The second novel method, and I'm about to wrap up, so I know I'm about to be at my time, is chart stimulated recall. And this was a method we brought in actually from the medical literature, where we asked clinicians to use their chart to recall what happened in session, and research staff were trained to do very brief interviews with clinicians about what they did in session using items that paralleled the TPOCs. And the idea behind that is that often it's hard to remember when you're back-to-back sessions what you might have did, and so that helps with recall, and it could be a way to exchange between the clinician and supervisor. That's how it's used in the medical literature, so it would be good for supervision, but that, it wasn't intended for mental health settings and does require training. And then the final condition is something that Shannon and I have been writing about for many years, which is behavioral rehearsal. Actually, we had to kind of develop it for this study differently than how we'd used it in previous studies. But it was basically a 15-minute condensed role play for the sessions that the clinicians completed. The therapists played themselves, and a trained research assistant played the client. And then they were coded for the components using the TPOCs.
And Rinad, can I add something before you go to your next slide? Sorry,
Yeah.
we're also good friends, so it's fun to go backwards. I just want to mention here, sometimes the things we think might be important before she gets to the results are very hard to study. And there was a moment where we almost gave up on this condition because we could not create what a behavioral rehearsal we could study. I mean, I remember being on with Rinad and Sonia before she gets the results. That's why I wanted to say it, but yours can go longer because this is some of what I wanted to talk about too. We almost dropped it. Remember, Rinad? We almost were like, we can't figure out how to. And this is where I think it's interesting is when you see the results, like sometimes the stuff we really need is very hard to study, and we almost dropped it and didn't study it. But I have to say that before she shows you the results. Okay, I'm back on mute.
And, I feel like having a great team that you can work through the hard stuff with, and Emily Becker-Hames was such an incredible partner and colleague in this work, helps you get through those hard times. Because I remember being like, I don't think we can do this. But it's a good thing that we did. And I don't have numbers to show you because I wanted to keep it brief. But these are kind of the main findings from the overall study, some of which is published, some of which is currently under review. So behavioral rehearsal really ended up coming out as the kind of strongest approach that produced the most comparable scores to direct observation. So, that was it. That was the big finding. We have looked, that's on the overall score. We have looked at the individual items, and chart simulated recall also produces comparable scores compared to direct observation on some of the items, but not on all of them. Self-report, it did not get there. And I'm sure there's a lot that could be done. And Erin Hogue has done some great work in this space on making self-report better. But what we did not do that, did not get us there. And, we have been working on some of the cost related stuff, and, obviously self-report is the cheapest. And behavioral rehearsal is more expensive, but less expensive than chart stimulated recall. And constituents report moderate to strong intentions to use these approaches in supervision. And so, I think that there's an interest in kind of taking these. And, in some ways, this was a little bit of a hybrid of efficacy effectiveness for measurement. And there's a whole nother set of work that needs to be done to actually incorporate and integrate into supervision if like that's the next step for this work. But I think my takeaway is that both behavioral rehearsal and chart simulated recall are viable options, particularly for those individual items that chart simulated recall worked for. And I'm always thinking about like, let's give our partners as many tools as possible and let them know the pros and cons, and then make decisions based on what works for them and their setting. And actually, Simone, who's a doc student on internship right now, and Emily wrote this paper recently on a case example of the supervision that Emily has led in the clinic that she leads, and talks a bit about how to kind of start bringing some of these ideas into community mental health supervision. And that shapes evidence-based practice delivery, what happens in supervision, as Rosemary Meza and Shannon's team have demonstrated. So that's it. I took too long, but thank you to the team. And here's my information, and over to Shannon.
Thanks so much, Rinad. That was excellent. Yeah, Shannon, take it away.
Okay, but I'm not finishing sending my note to Rinad. I was just going to say, if you can send me those slides, please do, because I had not seen the cost stuff yet. And then, of course, I want Simone's paper. So it's great to be here and to be here with Rinad, and to get to talk to all of you. So let me go ahead and just share my slides. I am going to jump around just a little bit because I want to build on some of what Rinad was sharing. And also, oh, that is the wrong order. Just a second. All right, now I'm in the right order. Okay, and be able to follow up on some of what she was just sharing. So, I think I love the stuff that Rinad said at the beginning, because I can just reinforce all of that. I'm going to talk a little bit about the things on this slide, like some real efficient and effective ways that supervisors and therapists can have a shared understanding of what's happening, because that seems so important, with the goal of supporting therapists, because like Rinad was saying, their job is so hard. And everything we've done has at times had the unintended consequence of making their job harder. But our aim is to support them and to get good clinical outcomes for kids and adolescents, which we all know. The reason I said I can support everything Rinad was saying is so much of what matters is relationships, connections, and experiences in settings. And, I feel like we need those relationships because we need to value the people we work with. But I think, everybody on this call knows, but I always like to say it. But that takes a lot of your time, and it is time well invested, and it is worth it. And you have to argue with your departments, your mentors, and other people for why that matters. All my students, when they write training grants, one of their aims is they have to spend time delivering care in the studies that we research, because if you have not, and they only do it for one day, we'll never know what it's like to be a community therapist in Washington. They used to make minimum wage. They don't now, it's gone up, but to make, to do that every day of your work, even if you intern there just one day, but that does make a difference. And those connections, experiences, and relationships do everything. Rinad, I don't know if you could see the chat, but Arthur Evans was here Friday, and we were meeting with him, and we were talking about all this work in Philadelphia. And he's now the president of APA, and he brings his experiences of everything he did in Philadelphia and working with Rinad and thinking about how APA approaches their work. So, I think one of the things we have to think about, and again, Rinad gave all these points, is what are the things that can work but that fit in clinician and supervisors' day and workflows? Because we have done such a great job in implementation science and in treatments and developing gigantic, beautiful programs that are really too hard to make fit within a clinician's regular day. Y'all are probably hearing this like we are, but agencies are hiring people they never would have hired. They're dealing with, attrition, with turnover, with much greater stress now even than they had before when they were talking about keeping the doors open. So, I have a graduate student who is looking at clinician burnout, and we were trying to understand some of the things clinicians wished their supervisors could do, their agencies could do. There are, of course, lots of things that would require new resources and require new money. But when we do prioritize clinicians' voices in the way that Rinad was saying and think about things, look at one of the things we've heard. I wish my supervisor could ask me about the vacation days I've taken. I don't take all my vacation days. I wish they would encourage me to take my mental health days, take my vacation. What an easy strategy to say you are more important than just the care that you provide here. And there were other things that people listed, But this, just encouraging people, because, you know, when you take more cases, because more people have turned over, you do start to feel I can't take my vacation days. And when you look at secondary traumatic stress literature, that's one of the biggest indicators that people are struggling is they feel like they can't be gone from work for a day. So this is really essential. So I just wanted to mention that one. And that's some work of Celine Liu, one of my graduate students. So, you know, I do want to go into a little more detail on Rinad's paper, because then I'm going to lead into one of ours where we talk a little bit about this and we use the behavioral rehearsal. So Rinad shared some of these slides with us. So here's the self-report versus direct observation. You can see the colors don't work perfectly, so sorry. The lower ones are the self-report. Sorry, the higher ones are the self-report. I'm sorry, my pictures are over my little things there. The larger bars are self-reports, so people are saying I did this at this degree. And then the direct observation is much lower on everything. And then when you look at, sorry, all my screens are in the wrong places to read my own slides. Just a second. Okay, so then when you look at, hold on one second. All right, when you look at the 3 conditions she was talking about, here's that one. All right, it's the next one I want to show you. She already talked about this. So this is behavioral rehearsal on each item and how it compares to each thing. So Rinad was talking about the overall. I showed you the overall. Here it is, item by item. Look how close it matches. Now, as Rinad said, this was really constructed to be a research procedure. We think it could be used in supervision, but I wanted to show you this before I talk to you a little bit about some of what we did. When you think about what can fit for clinicians and supervisors to have a shared understanding of what's really happening in therapy, if they can do a short behavioral rehearsal within supervision, you can get a real good sense of what clinicians are doing. And we saw in some of our data that if you encouraged a clinician to do a behavioral rehearsal, it actually elicited more modeling from the supervisors to show how you might do a strategy. And clinicians, despite all the things they're asking for, they're still asking for support in how do I deliver these the aspects of treatments that may be harder to do. So BR was equal to direct observation on almost all interventions. And this fits some other work Sarah Kate Bierman has done, where it's saying more practice, less preach, which is such a good title. Show people how to do things, have them practice how to do it. Don't just talk to them about it. And in some of our work in a supervision trial that we had where we looked at supervision techniques, we've got a paper that we're about to submit where the technique that included behavior rehearsal, but also a technique that combined looking at clinician self-report of what they did with client scores, both of those performed better on child outcomes than usual care supervision. And the reason I'm mentioning the child outcomes is the paper that's under review now that looks at Fidelity shows no effect, unfortunately, and it's direct observation as the measure, shows no effect of supervision on fidelity, but fidelity only matters to the degree that it improves outcomes for kids. And so in our study that looks at did kids decrease their post-traumatic stress scores, when they got a supervisor who looked at the kids' symptoms and who looked at what the clinician said they did in combination, because they give you a little more information that way, or when they did those things and had a short role play, then kids got better. And that seems to make a difference. And we did see also that when clinicians did a better job with the trauma narrative, kids' scores went down. So we saw on our direct observation measure that if you did a better job on the trauma narrative, that kids' scores did go down. So there's kind of a connection here. But all of these things are things that hopefully you could fit into the supervision you already do. If clinicians are not getting supervision, that's going to be very hard, and that does happen statewide. But when supervision happens, it does seem like there's some small things we can do to make a change in how it's delivered that help clinicians and supervisors have a shared understanding of what's happening in therapy and helps improve client outcomes. And my student, let me skip through this because I talked to you about, well, okay, I will say, one of the things we all need to do is make our materials more available. So we had these role plays that seem to be helpful. They're now all available on a state website that we have, and I'm glad to share later, that supervisors can go and get this information. And like Rinad's study that she talked about, the FACT study, this is a research protocol, so it has some stuff at the top on guidelines. But really what matters is show me how you'd introduce cognitive coping and apply it to a situation. And we kept it on one page because nobody has time to read 4 or 5 pages. So it's one page. And then an unattended benefit, as supervisor said, sometimes I don't know the treatment my clinician is trying to deliver, or I haven't done it as recently. So this is a good reminder for me, just the 4 little things at the bottom, like what are the expectations? What would you expect to see? Okay, so let me click. And people really liked it. They thought it was helpful. They thought it was worth their time. All right, let me jump through the next part I wanted to talk about. So Rinad mentioned my student Rosemary Messa's work. She took some data we had coding supervision and really looked at styles of supervision. What are the things that hang together that seem to make a difference? And this is one of the papers that I assigned as reading, along with a paper that Mandy Jensen-Doth, who is on here, has written with Bryce McLeod. So that's kind of fun to see Mandy and assign one of her papers. So this is Rosemary's paper about clinical supervision approach, and she did some very cool work that's a lot like latent class modeling. Latent class, what is it called? I always have word finding difficulties when I'm speaking out loud. But she did some work that's like that, but is a little better when you have a small sample. And what she was trying to look at is what were the techniques that supervisors were already doing. So we had not intervened. We had not asked supervisors to do those conditions I just shared. It just looks at what kind of goes together. And you can see there's strategies that we were thinking supervisors might do that fall in experiential learning, directive techniques, monitoring and quality assurance or elicitation. And you can see that these are some of the techniques we were coding on the left, but we wanted to see what people were doing. So when we coded this work, we saw they did some modeling. They didn't really do behavior rehearsal. We did see some didactic instruction and recommending elements. We saw some Fidelity assessment, but there was almost no monitoring of client symptoms or reviewing what the clinician had done before. And there's kind of there was a little bit of question and answer, but very little self-reflection, like questions that get you to think about, like, so what would this client need next? Or how do you think that technique benefited them? So all the conditions, though, we saw tons, sorry, not the conditions, all the supervision, we saw lots of supportive listening, praise, and empathy. So what Rosemary did was in our larger study in the baseline phase, which you can see there, what she actually did was took those recorded sessions and looked at these techniques. Let me jump into what she found. Just a second. And we were able to see that there were kind of 2 different supervision conditions. This undifferentiated low here, we call it actually supportive. And then the directive is supportive directive. Because what was neat is sometimes you hear supervisors fear that if they do modeling, they do suggestions, they do role play, that they lose space for support. But actually, both of these groups had tons of time to do support. But the ones that did directive were also able to incorporate some other strategies that you can see in the blue, like Fidelity assessment, didactic instruction, and modeling. And you can see in the undifferentiated low, which we called supportive. So that's another example. When we first developed it, we were thinking, well, it's a little undifferentiated, it's low. But nobody wants their supervision called that. You don't want to publish a paper where somebody thinks they delivered. It really was very supportive supervision, but it did not include these directive strategies. So that's why we changed the name. And one of the things that was kind of neat about it, so it had the supportive listening, it had the information gathering, but one of the things that we found was that the directive supervision, while it did not predict psychoed, relaxation, affective modulation, and cognitive coping, because a lot of clinicians are already good about that. So Brianna knows, as somebody who studied trauma-focused CBT a lot, people are pretty good at the early parts, which help get you stabilized, get you calmed down, developing skills for coping. But it's the exposure that's harder. And so we didn't see that the directive supportive supervision drove anything about what we call prac in TF-CBT, but it did drive the degree to which you delivered the trauma narrative. And in anxiety treatments, as we know, the exposures is the critical element. It's the things clinicians can be nervous about. And some of Rinad's work, led by others who've worked with her, clinicians have talked about being afraid of doing role plays. But when clinicians are supported with this directive style, and I think in a context of psychological safety, a supervisor they're connected to, it did mean that they were better able to deliver the trauma narrative. And the odds was 11.85 higher. So it's a decent amount. Now, the estimate is imprecise because of the sample size and what we were doing, but and what we were doing with the coded tapes. I can talk about that more later if you have the stats question, though I may need Rosemary. But it was 12 times higher when you had the directive supervision. So the last thing I want to mention, okay, here's Mandy's paper, but I'm going to come back to that. The last thing I want to mention is some work that another colleague of ours and a graduate student of mine, Clara Johnson, have led about using worksheets. And then I may jump back to this other paper. So again, I'm really interested in how can clinicians and therapists develop a shared understanding of what's happening, and how can they do that in ways that don't create new burdens, new work, new time. So if people have seen Shannon's work and Clara's work, what they've done is looked at worksheets as a tool. So many of us in practice, you see what a therapist produces or you see what a client does, and you can get a sense of what is understood. So what they did is they were really looking at, you saw some of the costs that Rinad presented about different fidelity measurement techniques. They really wanted to see, could some other things work? So here's the paper, leveraging routine clinical materials. And I think we need more work like this that takes the routine stuff that's already created. And they rated these worksheets for fidelity, and they developed a tool to do that. So this is kind of an example on the left of how you would do like observer rated fidelity. And then for adherence, oh, hold on, wait. Yes, sorry. This is the checklist. This is the problem with other people's work. This is the checklist for adherence on a worksheet. So the right is an example of a worksheet that you would have if you were delivering cognitive processing therapy. And on the left is an adherence checklist that you would use to review a client's worksheet. So I'll show you this and then I'll wrap up. So you can see in this one, an activating event, I was fired from my job, the belief I'm a failure, you feel angry and helpless. That is that's an event, right? It doesn't have any feelings. But a client who writes, I was fired because I can't do anything right, that's not just an event. That also has a thought embedded in it. And the therapist didn't catch that. So it's not rating so much if clients don't get it, but is the therapist working through with them what's actually happening and understanding the treatment well enough to get the worksheet. So, and then this one, I'm so mad at myself, is not really a belief. And so then their team developed this adherence rating for the worksheets. It does not take much time at all. And it reflected direct observation scores really, really nicely. And, you can see a little bit more about their scale here. Of course, we wouldn't ask a supervisor to use a scale like this, but this is the data to support that if you go through the worksheets, you can actually figure out pretty well if your clinician is understanding the treatment and delivering it as intended. So I'm going to flip through those, but they got really great outcomes. It's under review. I'm really excited for this work to come out. And I think it just suggests that, the worksheets can give you a real good glimpse at what's happening. And behavior rehearsal is super promising. And if you have self-report combined with something else, like client symptom monitoring, we might have a better chance at this shared understanding. So let me stop there. Here's my information, and excited to talk about questions and interact.
Wow, thank you.
I did want to show, sorry, I wanted to show one more thing that of course I can't see when I'm in the full screen. I'll just say this and then I'll stop. So I have a center grant that's been working on trying to develop some techniques and methods that could help you get into settings, try to understand more what's happening from the perspective of that organization and those providers. So let me just show you our center website really fast that I wanted to pull up. It's called the Impact Center. And we have toolkits here. These are all free. You can grab any of them. We have rapid evidence synthesis, because a scoping review and a systematic review is way too long to learn anything to help a clinic. We have causal pathway diagrams that help you try to match your implementation strategy to your barrier and understand how it's working. Rapid ethnographic assessment is one of my favorites because it gives you a quick way to go into clinics, to hear people's voices, to get a sense of the setting. And then if you're not sure which barriers you might want to address in partnership with an organization, this helps you prioritize it. And you can choose to weight things like equity or feasibility or importance. So you can make your decisions on how you weight it. Okay, I just wanted to show that. All right. And here's where the methods, you get the methods here. And then the website is here, mhimpact.org. I can pop them into the chat.
Amazing. Thank you, Shannon. That odds ratio was wild to see. Super
Wild.
impressive. Yeah. Like that should be posted everywhere. Really impressive. So thank you both for those presentations. They were wonderful and super informative. Before we open up to the audience, I thought I would maybe ask one or two questions. And I also welcome you both to sort of share reflections since you're both sort of collaborators. If, either of your talks made you sort of think of something. And then for the audience, just so you know, during the Q&A period, you're welcome to raise your hand and then I can call on you, but just do know that the panel is being recorded. So if you don't want to appear, you can just put your question in the Q&A button below. So I guess I'm curious about so many things about your work, which is really incredible. One thing I've thought about a lot is that clinicians are at very different developmental levels. So I've done a little bit of work trying to figure out how we can create resources and session planning tools based on Rinad's really important work, looking at how clinicians really value session planning and want to be incentivized for it. And one of the things I found was that clinicians, some say like, this would be great for a novice clinician, but I'm an expert and I need this kind of support. And so I guess I'm curious how you both think about clinicians' progression and development as practitioners and how that influences what you implement and how you support them and how you think about supervision strategies or worksheet strategies. Like, yeah, how do you think about modifying support as clinicians gain mastery in evidence-based practices?
Are you pointing at me?
I am, Shannon.
It's interesting because in the study we did on supervision, I tried to assess if people got the condition they wanted, like the therapist, and we tried to look at whether years of experience and even a knowledge test moderated the impact of like a supervision condition. So it's interesting because I have these beliefs that it should be different and change. And certainly I think some of our more experienced clinicians said, because we always want to look at the trade-offs, right? If you implement a strategy, what are the trade-offs? So we would say, we asked people what they thought was the downside of what they participated in. And some advanced clinicians said that when they did a behavioral rehearsal, they felt like they didn't have time to talk about as many of the cases. The interesting part is the data didn't really bear that out. Like I thought clinician knowledge, self-efficacy, I looked at a lot of ways to try to get at your experience with TF-CBT specifically, and it didn't seem to bear it out. And so it does make me confused about what to do, because I do think clinicians want it tailored, but I think even sometimes with experience, you still need more tailored support that with one case might then expand to helping you with all your cases. So I feel a little stumped and just humbly don't feel like I have an answer to that one right now. But I think supervisors who can tailor and tailor in the right directions do well. Our ICC data on the techniques supervisors use suggested that supervisors don't tailor as much as they think they do. So they will say, oh, I change it based on, but when we looked at it, it was really that there was, most of the variation was supervisors were seeming to do more similar things across all their clinicians. It's not exactly an answer to exactly what you asked, but the data that I have related to it.
Bree, it sounds like you've been thinking about this a little bit. Would you share a little bit about what you've found?
Yeah, it's a great question. That is a really helpful answer, Shannon. I think it's more just sort of prompted me to think about providing scaffolding for every level and resources for every level, which then I think the trade-off, as you mentioned, Shan, is that it's just more resources and more cognitive load. And so then you need to streamline the process of figuring out how to help clinicians know what to choose. And that brings us back to behavioral econ, I think, and sort of like making sure that the design is sort of seamless so that clinicians can access the resources that they think best fits them at the time they need it, which is challenging. Yeah.
Yeah. And I mean, I think my reflection from hearing Shannon's excellent talk was this idea of like, the more you can integrate into whatever is already being done in whatever environment, like you're saying, Brianna, that the clinician is working within, the better. But I also think sometimes when there's a really difficult case that someone's working through, you need that interruptive, like pull out of the workflow. And like, then you really need to, use some of these techniques to help. And I think just like I believe all as humans, we're all continuously improving and getting better. I don't think there's a time when you, as a clinician or as a human, can't improve more and need help, support and help with difficult situations. So I don't know if that's a helpful kind of add-on.
Yeah, no, that's a great question or answer. I see Esther Deblinger has a question. Exciting to have you here, Esther. Do you want to share your question?
Well, I first have to say how impressed I am with all of this research and how much I admire all of you. And I have a particular fondness for Shannon's work that I've enjoyed being involved in a little bit. And I wanted to just throw out the thought that you've all been emphasizing how extraordinarily difficult the work of mental health therapists is, especially the work that they do in community mental health. And how one of the things that we know about all employees is that something that they feel better about is having more autonomy and independence. And so I worry, about doing things that make them feel that they are being watched very closely or overseen, especially as they become more senior as clinicians. And so this has been this whole issue of how do you keep the outcomes positive and how do you support supervision has been very important to me all my career. We have it's not a community mental health center, but we have 25 clinicians working very hard, maybe primarily seeing children impacted by trauma. And I think that the biggest thing that we focus on that everybody seems to be comfortable with is the outcomes. And one of the things that I've struggled with in training community mental health agencies and TFCPT over the years is how few engage in administration of any measure at all. And it seems to me that that's probably the most important tool for supervision. Are your clients getting better? And I can't tell you how many times we've tried to be as much like a community mental health center as we possibly can so that we can relate to that work. And so we only use two measures. They're free of charge. One is measuring PTSD. The other is measuring behavior problems. And they tell us in some sense, they tell us about the clinician's strengths in terms of possibly delivering the trauma narration, as Shannon pointed out, that's one that we could sort of see is important to have that more directive supervision. And the other is the behavior problems. And that tells us how well the clinician is working with the parent. So I just go back to like your thoughts as researchers on, well, what about the outcomes as important measures, or are they doing the evidence-based treatment well? Because, if they found a slightly different way to do that evidence-based treatment and they're still getting really good outcomes, do we really want to fuss about that in supervision or at all? So that's sort of my question. It's an abstract question, I suppose, but I hope it's relevant to this work.
Highly relevant. And hello, Esther. Thank you for being here and for all the incredible work that you've done over the years. I've always been very compelled by that idea. And I think, the early work that Bruce Torpeda and other colleagues did in Hawaii also really kind of centered the outcomes. And I think your observation that clinicians want to have independence and autonomy in practice is spot on. What's been interesting, having been involved in some kind of measurement-based care work, is that I think that there may be a perception from some clinicians that outcome measurement is another way of taking away independence and autonomy. So they're kind of interrelated. And, my great hope for the field is that we could get to a place where there's a culture shift where outcome measurement is kind of a core part of treatment delivery, just like when we go to the doctor, we get a blood pressure check and our temperature checked. But I don't think we're there yet. And I think there's a lot of barriers, and I think I just think the work is really hard. And so just even reflecting on what Shannon said, I think she said that the different conditions didn't impact fidelity, but it impacted outcomes. And to me, like, that's an incredible outcome, right? But it also kind of puts on the head a lot of all of our emphasis on fidelity, because we actually see that frequently where we don't see the anticipated outcome.
We might have time for like one very brief question. I see a raised hand, so maybe we could make it like a 1-minute rapid fire before we wrap up, if that's okay. Yeah.
I think that might be my raised
Yes,
hand.
Barbara,
Okay,
yes,
great.
yeah.
Great, fantastic presentation. Thanks for all of this and lending your time. My question's about assessment, actually. So it's interesting that we just landed on outcome measures. I do a lot of training with community clinicians on how to do evidence-based assessment as the cornerstone of evidence-based treatment. And having a really hard time with folks sort of with the uptake of doing semi-structured assessments, and also getting clinicians up to an adequate competency level to be doing, semi-structured psychodiagnostic assessments and using certain measures. I'm wondering, how do you think about that particular piece of evidence-based practice, and any tips and tricks around that? Thanks.
Rinad, you should start on that one.
I don't know that I have a great answer for you. I like to present with humility. I've thought about this a bit, and my main answer for you will be integrating within whatever tools and tricks that they're already using, and trying to kind of slowly demonstrate the added value of the assessment tools that you'd like to add.
Yeah, that's a great answer. And a beautiful note to sort of end on, which is sort of meeting clinicians where they're at in the same way that we sort of meet clients where they're at too. So I just want to do another huge round of applause for Rinad and Shannon. Those presentations were fantastic, and we're so appreciative of your time to come speak with us.